we're really at a pretty exciting time. I've been working in this area for a couple of decades, and I think we are already starting to see a lot of change. I think we have the potential to see a lot more change and positive change in terms of how we view people, the autonomy we give them, the information we give them to make good decisions, trying to build the systems that support that, trying to fix our healthcare system, actually incentivize the right things. I'm hoping in 3 years from now, we're talking about, wow, we really took care of this opioid use disorder problem. Now we got to go deal with methamphetamine. But I think we may actually be there. I actually think that's possible. Those are not unrelated things. But I'm excited to talk about all this stuff with you. Super important, most important slide. No media person has actually ever asked me if I had conflicts of interest, so I always volunteer it for them. I do not have any conflicts of interest. I will tell you my funding so you understand it. I have a Centers for Disease Control project with the State Department of Health. I have some federal funds from the Substance Abuse and Mental Health Services Administration. I have some contract funds from the state block grant from the State Substance Abuse Agency. The only private funding I have is from a private nonprofit that's a criminal justice funder. And that actually is about trying to work with folks coming out of prison who have opioid use disorder and do treatment decision making and refer them to effective treatment services. And then I'm wrapping up, I have a couple projects from the National Institute on Drug Abuse. So I'm going to try to cover a lot. I'm going to talk about stigma. I'm going to talk about opioid epidemiology, prevention, treatment, and intervention. If you've heard me talk before, I would talk about any of those things happily for a day. So I'm just going to touch on these things. I'm hoping maybe you'll take 1, 2, or 3 things out of this that are interesting and useful for you. Pretty much everything I'm talking about is sitting on our website somewhere, so you don't have to take notes. So let's just sort of get into this. I think this is really important. And that the issue around substance use disorders, I often like to say, is we are all experts, we're just mostly wrong. We all have personal experience that we feel really strongly, and for some reason, for substance use disorder, unlike orthopedic procedures, we think we can generalize from an N of 1. We think we can say this did or didn't work for my Uncle Larry, and therefore I now believe this about everything. Whereas we do say that about, for instance, a person who's an alcoholic, we don't often say it about, do you choose a laparoscopic procedure for blah, 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 blah. But we do for substance use disorders. And I think it's fundamentally because they look like people are making bad decisions, then why don't they just stop making bad decisions? I think that's, and I'm going to unpack that. So again, we all have a lot of direct experience with people with substance use disorders, and we have a lot of different feelings around this, and we may have all of them at once, right? Sympathy, anger, and what I actually learned from a pharmacy professor is that it's really important for us to try to make explicit what our implicit assumptions are. It's really important. And there's no reason that we ever do this. Why would we ever do that? So I would encourage you, I don't know, while you're going for a walk tomorrow, to think about how do my own experiences shade how I see other people, how I think about this issue, how I treat other people, and how I talk about substance use disorders. It's really important. And it's amazing. We see it everywhere. I actually think one of the newspapers, it's the one I take at home, the New York Times, is horrific in how it talks about addiction issues. It continues to call people addicts. They generally put substance use issues, they put them in a style section on Sunday. That's where they talk about addiction. It's in the style section. It's just weird. It's just fundamentally weird. And that's a group of, I would think, fairly intelligent people at that newspaper. So just sort of extend that into any other arena you can think of. So the impact of those feelings, on your behaviors and your words and your actions, they're really important. And they're important to think about in all of your different roles in your life. So as a friend and family member, how do we treat other people? In your work. And as an expert in your community, whatever you are, you're going to be seen as a knowledgeable resource. And so hopefully having a little bit more fundamental understanding of what is opioid use disorder and what are the implications for treatment, and how can we, in addressing this issue, not just save a lot of lives, but restore a lot of people back to themselves. So just to kind of talk a little bit more about sort of the epidemiology. Don't worry, I am an epidemiologist among other things. I'm not going to do a lot of epidemiology. This is called squint epidemiology, what we're doing today, which is just squint and look at the trend, up or down. That's what I'll try to do, no statistics. And then talk about sort of how does this also play in stigma and rhetoric into care seeking. This is a really messy graph. I'm going to focus on two lines here fundamentally. So this is sales of opioids in Washington State to hospitals and pharmacies. This is tracked by the Drug Enforcement Administration. All of these data are online on our website. And the unit of so this is the year of sales. This is the total daily doses. So the y-axis is daily dose. And I actually can't remember what the different daily doses are, but it might be 15 milligrams for hydrocodone, and it might be, I'm going to say something wrong, that's fine, and it might be, I'm going to say it wrong, 20 milligrams for morphine. I don't know what it is, but I'm trying to get them all on the same plane, because fentanyl is so much more potent than morphine, you want to turn it into a daily dose. Okay, why am I yammering on like that? So this is, this line here is all opioids together, and there's some messed up data back here, so it's hard to trend. But believe me, this line, believe me, I can't believe I used that guy's line. Believe me. Trust me, no, dang it. Verify. This line goes like this. This is total opioids, right? And the point is up here, that's 111 million daily doses sold in Washington State. 111 million daily doses. That's a lot, right? That's a lot. And this has been going up, and we've made a lot of changes in Washington State. We're ahead of most of the country in terms of kind of reining in opiate prescribing, and we've seen a change pretty modest. It's pretty modest. And just to share with you this one, to give you one example, this is hydrocodone, which has driven a lot of this. It's responsible for 50 million of these daily doses. That's Vicodin and those types of compounds. Again, a modest change. So there's a lot to unpack on that slide. I won't go into it too much except to say that phenomenal increase in opiate prescribing and a modest decline. And what we're seeing in all the data is around 2010, 2011 is where that starts to change. And that has to do with probably, we don't have any proof, several things, including a lot around state guidelines is a big issue. OxyContin was reformulated so it could no longer be crushed and snorted. It became much less interesting as a diverted drug. And then we actually didn't even get the state prescription monitoring program till out here. So people always think it's the PMP, it's not. Okay. So opioid prescribing, super high level. About 1 in 5 adults gets an opiate prescription each year. Depending on what population you look at, about 2 to 4% of adults take opiates chronically for a chronic pain condition. About 1 in 10 adolescents is prescribed an opiate each year. And that's really important because the peak age of first misusing opiates is 15. So that's a really important age group to look at. So just to give you some sense of what's going on here in terms of the front end, right? The new cohort of young misusers who will be the future people who become addicted. We added a question to the State Healthy Youth Survey back in 2006. Have you used prescription type opiates such as Oxy, Percocet, whatever, to get high in the last month? It was 10% of high school sophomores in 2006. That's 3 kids per class getting high in opiates in the last month. That's really high. And it's come down, which is wonderful, to 4%. You know, 0 would be better. It's coming down, but there's still plenty of work to do there. So the point is it's still fairly prevalent. All these things we're talking about look like they've had some impact in preventing inappropriate initiation and use of substances. But even within high school sophomores, we find a very strong association with heroin use. If you have not used prescription opiates to get high, 3% had ever tried heroin. If you had ever used prescription opiates to get high, 27% had used heroin as high school sophomores. So this is treatment admissions, publicly funded. You've never been in drug treatment before. You're coming in for the first time and heroin's your primary drug. So that's a weird situation, right? Normally you'd come in to be alcohol or marijuana, you'd think. So back in 2002 it was 700 folks. In 2015 it was 2,300. This orange group are 18 to 29-year-olds. This is a young adult phenomenon. And this matters because opioid use disorder is a chronic condition. And if we want to help these young adults become old adults, we're going to have to think about some really substantial things to do to support them. This is statewide opioid mortality. The takeaway here is that we're flat. All opiates combined, the death rate is flat at about 11. Pharmaceuticals have come down somewhat. Heroin has more than replaced it. Or not, I'm sorry, it has not more than replaced it. It has essentially replaced it. They're mirrors of each other. So reining in opiate prescribing did not fix opiate use disorder. Not that everybody dying here has opiate use disorder, but about half these people have a prescription and half don't. So addiction, opiate use disorder is a major component of what we're seeing. Among those who do have prescriptions and are using as prescribed, they may well also be using a third of them, their benzodiazepines as prescribed, and their alcohol not as prescribed. That's very common. So what's interesting in my line of work, which I didn't really get, because when I did my social work training, my first internship was in a methadone clinic. I just didn't understand what the stigma was about. So what's interesting to me is how much there's as much stigma around people who have opiate use disorder as there is around the treatment medications, which is really stunning. And it's also among the people who have opiate use disorder. It's why they don't want to get on treatment medications, and if they do get on treatment medications, they want to get off of them as quickly as possible. So we're starting to really try to get information out to folks around opiate use disorder, both for professionals and the general public. This is a big enough issue that I think the general public has pretty broad interest in it. They don't have very good information. I'm not going to go through this in much detail at all, except to tell you that opioids act on opiate receptors, and they have an effect similar to morphine. You have receptors throughout several parts of your body. They have a number of different medical impacts on the body. You've probably heard them several times today in the last couple of days. Really important just to remind you, if you think about our endorphin system, what that word means is endogenous morphine, right? So your body's naturally made morphine. That's really important, right? This is not a random thing that we like opiates. I'm going to skip that. So opioid dependence is really important. You've probably heard a bit on this as well. I'll try to skim over it. So it's a physical state. We all take opiates 4 times a day for a month. We're all going to get opiate dependent. That just happens. That's physical dependence. You're going to get tolerance. You need more to get the same effect. You stop using, you're going to go into withdrawal. I think withdrawal is kind of, I don't think people have a true sense of what that's like. The best analogy I've heard from folks is, that time you had the rotavirus and you slept on the bathroom floor and that cold tile floor felt so amazingly good. It's like that. You feel like you're dying. You feel horrific. It's not like, oh, my nose is running, I'm a little itchy. You feel horrific. That is a serious negative reinforcement encourages a person to use. And in the sort of, I think, proper use of the word tragic, the challenge with opiate addiction is you start off using to feel good, and you keep using to not feel bad. It's horrific, the state you end up in. So I talked about that. There are changes to the brain. The natural endorphin system can be very disrupted. We don't really understand it that well. We really just don't understand it well. We don't know how long-term or permanent it is, but it is substantial and long-term. And again, I like to say a person may make choices to use opiates initially, but the structural changes in the brain mean that for most, it's very hard, if not impossible, for them to simply make a choice to stop. So the head of NIDA says you behave your way into the condition. It's almost impossible to just behave your way back out of it. So opiate use disorder is really important, and the focus is on the dis and disorder, right? So it has physical dependence, but it also involves psychological impacts, compulsive use, preoccupation, you're thinking about nothing else, and really a reprioritization in your life, where you really truly value opiates more than food, water, love, like fundamental things in your life. And then, of course, that's going to dramatically impact your social functioning in terms of relationships, work, and school. So opiate use disorder is all of those things. And you keep using even though it's hurting you. You try to quit and you can't. You spend lots, if not all of your time using and recovering, and you end up using in dangerous situations. So some people get opiate use disorder and some don't. About 1 in 4 people who ever try heroin become dependent on it. I know Dr. Frank spoke about the proportion of folks that's roughly similar of adult men in China more than 150 years ago. It's a similar proportion. Some substantial proportion is predisposed to liking and getting addicted to opiates. And it's a mix of things. It's genetics, there's personality type, a history of trauma, physical and emotional is really important and fundamentally important as well. Particularly if you're thinking about adolescent exposure and really how do you be careful about that. And then the mindset and social setting, like all addiction, is really important as well. And I don't know if Dr. Lozier spoke about this, but there's very different things happening in terms of whether you've had major surgery and you have a morphine pump and you're in a hospital versus whether you're shooting heroin at a party. And maybe I missed it, maybe he found the answer since I've spoken with him last, but why? We don't really know. We know, and there's other strange things, like you're more likely to overdose if you're in a new situation, if you're in a different environment. We know it from rats, we know it from people. Why? We don't know. There are really odd interactions between brain and biology dependent upon environment. Okay, so why are we doing a treatment or management? So you're trying to give people tools, behavioral tools, environmental change, medications to help people manage their own opiate use disorder. You want to teach them how to use those tools and really help them facilitate a continuing care model, which is kind of our job as systems to set up, and collaborating with patients to adapt treatment as their needs and circumstances change. This is so not a one-size-fits-all model, right? Like any area of medicine. And I think that's kind of my point. Like any area of medicine, it's not one-size-fits-all. So opioid use disorder has brain changes and dependence, psychological and social problems. So if you can get opioid use disorder treatment medications in here, and you can get the dependent piece met, either by getting a person on opiate so they're not going into withdrawal, or giving them an opiate blocker, which I'll talk about, then the person can get off of the roller coaster of opiate use. You know, whether you're talking about OxyContin or heroin, you're talking about a person using it multiple times per day. You're literally on a roller coaster. I can't fill out a job application on my laptop while I'm on a roller coaster. Right? I can't be a good dad when I'm on a roller coaster. So we're just trying to get a person on steady ground as a starting place, so then they can deal with the rest of the things in their life. You know, and that's where counseling and social supports can come in. I say something that's pretty controversial to regular people. It's not controversial in the medical science. Counseling and social supports are invaluable for some people, but they are useless for some people also. And we've made mandating counseling and social supports often prevent people from getting access to treatment medications. And that's a fundamental problem, and I'll talk more about that. So the idea is, well, aren't you still addicted if you're on a treatment medication that's also an opiate? And the point is, no. What's the definition? It's not just physical dependence, it's the chaos. It's the disorder that a person's life is in. And the message that I think has really resonated with people is that you can be on treatment medications that are opiates and be physically dependent and out of the disorder and be in recovery. You can be in recovery on treatment medications. That's fundamentally important. I said that to an audience, and this gentleman came up to me, I think probably in his 50s, and he had been on and off of opiate treatment medications for most of his life, because whenever he was doing really well, he wanted to get off because he was just perpetuating being an addict. He'd never thought about staying on them. Like, I'm doing well on my Wellbutrin, I'm doing well on my insulin. You know, we don't think, oh, I'm doing great, it's time to get off. But we do with treatment medications. It's fundamentally different. So what are these medications? Just very quickly, this is all online. So methadone, which is a full opiate, the more you take, the more effect you get. For opioid use disorder, you can only get methadone in large, highly regulated, high-frequency visiting treatment clinics that are difficult to cite. There are slowly becoming more of these clinics, but they are difficult to set up. So methadone as a medication can only be obtained for opioid use disorder in these large programs. Buprenorphine is a partial opiate. It's a partial agonist. It has essentially a ceiling effect. It's a safer medication by itself. And it can be used both in an office-based way, both now prescribed by nurse practitioners, PAs, and MDs. That is new that PAs and NPs can do that this year. But it can also actually be used in an opioid treatment program. And in fact, we're doing a lot of work right now I won't go into about how do you set up opioid treatment networks and get a person started safely on medications as quickly as possible. How do you get them through kind of a protracted stabilization period? And then where and how do you do maintenance in an ongoing way? And really trying to set up networks for how to do that based on both the care setting, the access points, geography, transportation, the really complex lives that we're living. So again, methadone, as a side note, is a Schedule II substance, DEA controlled. Buprenorphine is a Schedule III. So buprenorphine can also be, as I said, prescribed and picked up at a pharmacy, which is very different than going to an opioid treatment clinic and taking it in front of a person 6 days a week. And then a newer medication that does not yet have good effectiveness data, but definitely works for some folks, is a medication called naltrexone. It's an opiate blocker. The more you take, no difference. You're just straight up blocked on opiates. And when it's used for opiate use disorder, it's also used for alcohol use disorder. But for opiates, it's generally given as a 30-day injection, that substance. So really importantly, there's really great research out there that shows for buprenorphine and methadone, huge trials and observational studies, for instance, and I'll show one of them, of 150,000 people, that these medications have very positive economic outcomes, that they reduce mortality by 50%. They're some of the most effective treatment medications for any medical condition that can get used. The challenge that comes up that I hear all the time is that methadone can get diverted and sold on the street. That is true. It can. Buprenorphine, same thing. What we find is that there are very different reasons that people get these drugs off the street. Diversion is a big concern. What we're seeing is that diversion is very high in places that don't have enough prescribing. And if you ask people to get buprenorphine off the street, why are they using it? They're using it to try to self-detox. They're not using it to get high. It's a very different motivation. So I think it's very important. If you're really only going to get a euphoric effect on buprenorphine if you're not opiate tolerant. If you're opiate tolerant, you're not going to get much effect from buprenorphine. So this is the study I mentioned in the United Kingdom. They followed 150,000 people with opioid use disorder over time, and they compared their mortality rates when they were on medications, when they were just in counseling, or when they were not in treatment. And when you were on medications, you had a 50% lower mortality rate compared to not being in any treatment. You also had a 50% lower mortality rate compared to just being in counseling. That's very important. When I say that, as also a social worker who likes talking to people, there is real value in counseling for a lot of people. In a research study, the way to interpret that is the average counseling for the average person doesn't have an effect. It doesn't mean good quality counseling delivered in an appropriate way and setting that is patient-centered won't have an effect. It's just saying statistically, on average, it doesn't, which means we need to be cautious about mandating it for folks. And to that point, actually, state Medicaid actually removed rules that did mandate counseling along with buprenorphine a couple of years ago. Because it ended up being a barrier in many rural communities. They simply didn't have counseling partners. And so instead of people being on a life-saving medication, they just weren't giving anything because they weren't able to get the counseling as well. So comorbidities. So opioid use disorder is often comorbid with chronic pain. I don't know what the exact right percentage is, but it's at least 40%. It's at least 40% of people with opioid use disorder have a chronic pain condition. And I can just say that because that's about the chronic pain prevalence of people 50 and older. And then we also know that folks who are coming in through this pathway are more likely to have chronic pain. Mental health, anxiety, and depression are hugely overlapping and in fact may be the same condition. We call them different things, but that's how, because we like to classify things. And a lot of other health conditions as well. So I think what's really important, and I'm gonna touch on this quickly, but I think it's another way to see the same information, and I'm all about getting information in different ways. So I often will do, the next slide I show you is I'll go to a community talk and I'll use this single slide. And the question I get asked all the time is, how do you go from taking a pill to shooting heroin? That doesn't make sense. And right, that doesn't make sense, because it isn't that I took a pill today and I'm shooting heroin tomorrow. That's not how it works. So let me just sort of walk through this. I mentioned a little bit of this earlier. So you have to try it, right? That's obvious. But that has to do with access. You have to have access to the compound in order to try it. Sounds really obvious, and it is really obvious. So you really want to prevent inappropriate initiation. And so there's a lot of work being done increasingly, particularly around working with dentists with adolescents, and the very high prevalence of opioids being prescribed for dental extractions. And that I'm not a physician, but that generally is unwarranted, and you're just creating this supply of drugs sitting out there. I mean, the common story is the kid who got their wisdom teeth taken out, didn't use the opiates, took the opiates to the kegger and shared them with his friends. I've heard that so many times. It might even be true. I don't know, probably not. Just like the farm parties, I kind of doubt it. But the other part of trying it is motivation and wanting to try it, and or thinking that it's safe to try it, right? So the big thing going on right now is we're seeing more fentanyl, and we're seeing fentanyl sold in Oxy 30 tablets because it looks safer. Like it has this aura of safety. That's a big problem. Then there's this piece we just talked about that you actually have to like it, and there's a lot of things about what liking means. And if you do like it, and you like that high, we talked about tolerance, you're going to use more and more and more and more. And then you're going to find out that taking it by mouth is really inefficient, and you're going to snort it or more likely smoke it. Tons of smoking out there right now, both of pills and of heroin. And at that point, if you're smoking heroin, you're just going to go ahead and move on probably to injection at that point. To be really clear, this isn't happening in isolation socially, right? This is a person moving it through different social networks as this is happening. And then by the time you're injecting pills, if you can even get them anymore, you might as well switch to heroin. And here's why. So this is oxycodone, right? And this is morphine. So your brain takes heroin and converts it into morphine. And you'll see they're basically the same thing. And they're biological equivalents. You can swap one for the other, basically even Steven. But they're not cost equivalents, and the availability is very different. So you can't even get an 80 milligram OxyContin anymore. But you're talking a lot more money and a lot less availability for pharmaceuticals than heroin. And we're getting heroin and fentanyl, really importantly, and I really need to update all my slides now that we're seeing more and more fentanyl, because we basically have pharmaceutical opiates and we have illicit opiates, which could be heroin or could be illicit fentanyl and other related compounds that are out there. And the fentanyl is generally getting sold, just so you know, as a powder or as fake oxy tablets that people may or may not know what they're using. Just to remind you, fentanyl, very, very potent substance, getting used illicitly. There's no quality control. You have no idea what the dosing is going to look like, and that's part of the reason it's so dangerous. Talking with people who have opiate use disorder. So this is something I'm really excited about. So you're probably familiar in this room with sort of this whole idea of shared decision making. There's a little clinical trial going on in, I think, Minnesota to try to adapt some shared decision making around opiate use disorder for physicians. What I'm actually working to try to do is to push this out further into the community where people with real opiate use disorder are. So whether it's at a community corrections office or at a syringe exchange, or maybe people calling a recovery helpline, that's where we're going to find a lot of folks. So the idea with any shared decision-making process is you introduce it, you describe the health problem, the treatment options, what are the decisions to be made, sort of just any background information about the condition so people really understand it. And with opiate use disorder, I think there may be a lot more confusion than other things, particularly since people often have a very social context to their use, and they're getting a lot of misinformation from their friends, right? That, again, different than you might have for the person going to get hernia surgery. They may have heard bad rumors from their friends, but not like you're probably going to be hearing about opiate use disorder. You want to compare options. You want to give accurate information on the similarities and differences between treatment options. And so the idea here, and I completely just ripped this off right from depression because it's the same thing. You can do watchful waiting, right? See what happens. If you're coming out of prison, you had opiate use disorder before, you can do nothing. You can watch your cravings, you can watch your triggers, you can see if you relapse, you can see if you start drinking. You can just do that and observe. That's something you can do. Really seek out social support, and we really unpack what that is. I actually am working on this morning. So social support is important. People think, oh, you mean 12-step. And we do mean 12-step. AA or NA might be fine. For some people, I like to say 12-step works great for the people it works for. But for the people it doesn't, telling them to keep going back and that it's their problem if it doesn't work is also messed up. That's uncool. Because there's not great evidence for this that on average it works for most people. There's some people it works for and many whom it does not. There are other options. There's smart recovery. There's more of a, quote, evidence-based approach to social support. And then I try to remind people that social support looks like a lot of different things. You may find that a chronic pain support group is actually going to be the most meaningful support group related to your opiate use disorder. That may be the thing that is most important for you. Or it might be some exercise club, right? Social support means a lot of different things. In the treatment world, people think of 12-step. But social support means a lot more than that. We all need it, right? That's something we all need just to be healthy, happy people. And of course, in this instance, trying to make that explicit and trying to create safe, supportive social support networks for folks. Really important. Counseling, whether it is chemical dependency counseling and or mental health counseling. We have a real challenge I will just mention in this room, and that the training for chemical dependency professionals in Washington State either basically does not address treatments for opiate use disorder. And talking with one of the folks who leads one of those for a local community college, they said, the amount that I know about opiate use disorder treatment medications could fit in a thimble. And they lead the curriculum for one of the training programs. That's a problem. That's a problem to have folks out there who are doing this work and often getting reimbursed for 2 to 3 hour chemical dependency assessments who actually fundamentally don't understand the evidence-based treatment interventions for opiate use disorder. That's a challenge. And it's a challenge for the State Department of Health and thinking about who is having oversight over that group. My understanding is that the physician role has been vacant for a couple of years despite applicants. So there's serious, serious workforce issues in terms of the counseling component for opioid use disorder treatment within the chemical dependency professional area. I'll also say I work with a lot of chemical dependency professionals who are awesome and informed and know how to do this work really well. They are the exception. They are the exception. And it's understandable why they're exception, because they're not trained that way. And most people who are coming into being chemical dependency professionals have a history of their own being in recovery, and usually related to alcohol use. And we have a long history of confusion in this country about what is effective treatment. And it comes out of 12-step Minnesota model, and it comes out of alcohol. And I keep getting confused because I got trained and started working in a methadone clinic, and then I go out and talk to the general public, and I get confused because I say treatment and don't realize that we're thinking of very different things. The general public thinks that treatment is detox and inpatient. That's what the general public thinks are drug treatment. And for opioid use disorder, those are not complete treatments without medications, and in fact, increase relapse and mortality rates. That's pretty important to think about how you're going to frame the counseling options for folks. So you want to make sure you're getting people that counseling that is effective and actually matches the evidence base. And then we talk about medications, and that there are, of course, pros and cons of all these medications. There's no one right fit for everybody. So we sit here and we talk about next about their views. Here a person is asked about their personal likes and dislikes about different treatments. One of the things in particular, if you're dealing with people who've used opiates illicitly off the street, they've all also purchased Suboxone off the street. And some people like it and some don't. And what's really important, and we spend a lot of time on this, is people understanding if they say they don't like Suboxone, we have a series of questions. What's your overall impression? Where have you used it? Have you used it from a healthcare provider? If you say you didn't like it, is it how you felt on it? Did you take somebody else's split dose? Did you take it within a couple of hours of using opiates? Those questions, those last two questions, are basically trying to find out, did they get too low a dose, or did they take it the wrong time and put themselves into withdrawal? So induction on buprenorphine is managed carefully by a medical provider, probably less so on the street, right? So we're really trying to unpack that. Similarly with methadone. Do you not like how you felt on the medication? Did you not like the rules? Did you not like the clients? Did you not like the counselors? And that matters because now we have these care settings where now buprenorphine can get used in an opioid treatment program. That's new. Now we have lower barrier buprenorphine programs that I'll talk about. So if you actually felt like okay on that medication, but you couldn't navigate a primary care system, like most of us, right? There are other options. There are other ways into a care system. They may ultimately get you to primary care, but not managing 3 assessments over 12 weeks before you get your medication, which is not a typical way into buprenorphine through a primary care setting. So we really want to understand people's views, because this is about them and them owning this and understanding this, just like we would with depression, just like we would with hernia surgery, right? And I say that because, of course, I got hernia surgery, and I'll tell my medical story now. But the point is, I met with a surgeon. He told me all the options, and here are your options for surgery. And I said, oh, that's great. What should I do? And he said, well, you just make the decision. I gave you all the information. I'm like, right, but how do I make a decision? How do I make that decision? And he didn't have an answer, so thankfully I went to the Scottish National Health Service webpage as I did my research on treatment decision-making, and they had like a 4-item decision-making tool for surgery. Do you want a general anesthetic? Do you care how big the scar is? Turns out I did have preferences on those things that I'd never thought about before because they were implicit, and they were really important to make explicit so I can make an informed decision. So your trade-off. So going through the pros and cons of all of these. There's pros and cons of every one of these things. Nothing is perfect, even close to it. And then supporting people in their decision. How do you really help them get started and engaged, and then realize this is a highly iterative process. This is not a one-and-done thing. And that's really important as well, because when it comes to substance use disorder, generally speaking, and I'm generalizing, people get on certain tracks. If you're poor and you're a heroin injector and you got on a wait list for methadone off a syringe exchange, you show up at the methadone clinic and they tell you how things work. If you have good insurance and you get a referral to a primary care provider and offer buprenorphine, that's how buprenorphine works. Well, there's actually a lot of different options and a lot of different care settings. So can we give people more decisions and more options earlier upstream in this process? For me, I just have to share this with you. After spending about 15 years telling people, do you know the evidence base for methadone and buprenorphine? Why aren't you doing it? Which didn't work very well because half the people said, I don't care. I don't care. I don't like it. I don't believe in it. I'm not going to do it. You can't make me do it. When you explain a shared decision-making model and that people who have a medical condition deserve to understand their medical condition and have a voice in their care decisions, that's been a lot harder for people to argue against. And I've seen a lot of systems kind of come around with that reframe. I'll just mention a couple of the projects we're working on. So really high level. So I have a little study, as I mentioned, for people coming out of prison. We're meeting them in community corrections offices, doing treatment decision making. Super challenging place to try to do a research study. Just going to share that with you. I will tell you what was interesting, though, is that I've had wonderful meetings with the community corrections officers and talking about that treatment decision-making framework. They were actually the ones that said, oh, well, maybe I shouldn't send them to that recovery house that doesn't allow them to be on medications. Maybe I shouldn't send them to the counselor who won't support them being on medications, if that's an option they may want now or even later. Because if you send them there, you just shut a whole door on a whole treatment option that has the best evidence base. And that was totally their realization in that process. So it's been really valuable. What's been exciting in that process of working with the State Department of Corrections is that things have really changed. We've had a lot of culture change there in the last 2 years, to the point that with some of the Federal CARES Act dollars, they on their own put in a modest proposal to implement this treatment decision-making in 4 violator facilities. I know, I'm using their language. In 4 facilities for people who are coming in for short stays, usually due to drug-positive urines. So we're implementing this in 4 facilities, and I'm going to be evaluating that with them. So we're really kind of rolling it out, and I've been very clear with them as a researcher. Makes me very nervous because I don't know if it works. I know shared decision-making works. I know the pros and cons of these different treatments, but as a researcher, you don't yet know if you're actually improving outcomes. So we'll be testing that, and I've been very clear with them about that. So let's see. We're also working on implementing this with CARES Act funding. 6 they call them hub and spoke models for opioid use disorder treatment medications are set up across Western Washington. I'm providing the technical assistance for those projects and working with a lot of different providers. There's a list of about 50 of them that include prescribers, but also people doing case management, upstream case management, downstream case management, getting people to care, working with them on treatment on demand, and then a lot of work with the State Recovery Helpline. So I'll just mention you, we have a State Recovery Helpline. And there are sort of 2 scenarios that we're trying to avoid that happen commonly, in which they don't want to have happen. Mom calls in, my 17-year-old's on heroin, I got to get him in detox now. So they tell him how to get in detox. They don't say, that's not complete treatment for your son. What are you going to do in addition to and after that? So we're working with them on that piece. And then the other piece of this is, person actually calls and says, I want buprenorphine. Where do you live? Who's your insurer? Okay, here's the 6 providers. They call back 20 minutes later. They're not taking anybody. So we're trying to build both a protocol for staff to have basic informed conversations with folks, a real-time buprenorphine directory, and then kind of a complementary website so people can actually go on there and try to navigate this information to some degree to themselves. We're really trying to get them to talk with someone, either the helpline and or their medical provider. We're just trying to let people know that there are paths. You don't have to be stuck in your addiction, that there are paths, and it looks like, based on these things, this might be a path to try first. Talk to your medical provider or talk to your community treatment provider. And all of this is in the context of a broader sort of plan, sort of my strategic plan is that you're trying to build treatment capacity, right? As systems, we've been trying to build capacity in an incremental way. We're making some progress. We're definitely making progress, but there's a lot more to do. You actually have to build demand. And I was reminded that we've actually had to build demand in the past for cancer treatment and for depression treatment and so on. So this isn't novel in the history of medicine, but it is important now that most people don't understand that opioid use disorder is a medical condition, that it's treatable, that medications are a frontline gold standard treatment, that medications support recovery and reduce mortality by 50%. That is not something the general public understands. And I'm very clear in all that medications are not the right thing for everybody. Very clear. That it really is about treatment decision making. It's about finding the right fit. But in my conversations with dozens of addiction medicine docs, they're very clear that the majority of patients are going to do well on opiate agonist medications for a while. That is the normative thing. That is the typical thing that they see that is successful. And then the other piece we're missing is, so build capacity. We spent lots of time as a system doing that. We're doing more work to build demand. And then you actually have to connect people to care. So that's the work we're doing with the recovery helpline, and it's the work we're doing within these hub and spoke models where we're not just getting more providers waivered, we're not just getting more behavioral health supports, we also are getting paid staff to sit at syringe exchange, jails, and ERs to actually identify people where they are, do treatment decision making with them, hopefully have access to the treatment system's EMR and get them scheduled for the next day, and if they're in a care setting, actually get them started on buprenorphine then, and immediately connect them to care. Is it going to work every time? No. Is it going to work some of the time? Yes. And given the scale of the problem, I think that's going to be good, and I think we can just keep building momentum on this work. I'll mention one quick thing that we have going at the Syringe Exchange in Belltown in north of downtown Seattle, which is a buprenorphine pathways program. And the idea with that, they hired a full-time nurse care manager. She spent every afternoon doing drop-in appointments, which is fundamental to actually getting people seen, is to do drop-in appointments. As pain in the butt as it is doing drop-in appointments is essential. And she could actually do phone-based consult with a physician. There's a pharmacy on site and get them started on buprenorphine that day. They were pretty much full in 3 months, 98 patients. They had a 2-hour, people would line up 2 hours early to get into these drop-in appointments. So we're working to sort of build that capacity. We had a funny conversation. I don't think he would mind me saying this. We were on a call a couple days ago with Andy Saxon, who's a psychiatrist at the VA. And they also then implemented a low-barrier buprenorphine program because they said all the people who had appointments didn't show up, and the people who didn't have appointments did show up, so why are we wasting our time with appointments when we're talking about people seeking treatment for opiate addiction? So just to remind you, it's out there, the State Opioid Response Working Plan. This is actually an outdated version. This plan actually, it's housed on our website. I know it's kind of a weird place to put it. It's actually on the stopoverdose.org website. You can find the State Opioid Response Plan. The plan overview, not a big shock, is guess what? We should prevent opiate misuse and dependence, treat opioid abuse and dependence, prevent deaths from overdose, and of course, do really good data tracking and evaluation. And trying to think at the individual level, the professional level, communities and systems, right? In other words, we should be doing everything. Again, I think some of what you've already been hearing around prescribing is reducing prescribing in adolescents, preventing unnecessary initial prescribing, prevent long-term prescribing when it's unnecessary. We know that the information we got into this situation with 10 years ago was incorrect. We were basing information on chronic opiate prescribing on evidence that lasted 12 weeks. And the research I did with group health, people on opiates an average of 5 years, right? That's very different what happens in that, over that time frame. I just want to say there's more evidence about this, that sedatives are a huge piece of this. My read of the literature is they are a much more important thing than dose. I'm not a medical provider, but I would encourage you to really look at the research and look at that carefully. Benzos are a huge issue. And if you look at yes, you're at high relative risk if you're on 150 milligrams morphine equivalent. But most people are on 20 milligrams and using benzos, and that's where most of the overdoses occur. So there's relative risk, who's at the highest risk, and then where is actually most of the harm happening. Those are very different things. King County Task Force, you set me up for it, Mimi. So we talk a lot about what we call bupe first, or low-barrier buprenorphine, getting buprenorphine inductions in a lot of new care settings, and also seeing, and I think this is really important around safe drug consumption sites, is that the data I didn't show you, but from our state syringe exchange survey, we just asked this in King this summer. We asked opiate injectors, would you like help stopping or reducing your opiate use? 80% said yes. Would you be interested in treatment medications? We asked, and they got to list the treatment medications. 80% said buprenorphine or methadone. In other words, 64% of people who are active injectors want to not be using and want to be using the effective treatments. So that seems like a peanut butter meets chocolate situation. Let's just get these things together here. And the point is, but 20% did not want to stop or reduce their use. I like people, I like them alive, and so that's where a safe drug consumption site comes in. That 20%, what are you going to do for them? What are you going to do for them? So if you picture showing up at a syringe exchange, we're giving you clean supplies and equipment. Behind door number 1 is a nurse who can help you get started on buprenorphine today. And behind door number 2 is a nurse who can watch you use and make sure you don't die. That's the idea. This isn't like, let's just start throwing this out willy-nilly. It's very purposeful and thoughtful, and it's where that language around community health engagement locations comes from. I actually don't know why I ended on that because that's not my main point. But here's a lot of information online. This is my last slide. Everything's online. I think we'll stop there. Thank you very much.